Welcome to The Explainer. You know, pancreatic cancer has this reputation for being incredibly stealthy, really tough to catch early. So today, we're going to trace the exact step-by-step clinical journey that doctors and patients navigate together. We'll go from the very first subtle clue all the way to a potential life-saving treatment plan.
So here's our roadmap. We're going to follow this thing just like a patient would. First, decoding those initial signs. Then, the whole medical investigation. After that, figuring out what's really going on inside, staging the battle, and finally, cracking open the treatment playbook.
All right, let's get right into it. Every single medical investigation kicks off with those first few clues. And with pancreatic cancer, man, these clues can be so subtle, you could easily just brush them off. So what are doctors actually looking for?
So what doctors are trying to spot is a pattern of what they call constitutional symptoms. You know, things that affect your whole body, like losing weight without trying, getting night sweats, or just completely losing your appetite. But the big one, the real initial warning sign, is often progressive jaundice. That's when your skin and eyes start to turn yellow. And that's happening because a tumor is physically blocking the bile duct. The tough part, persistent pain, well, that can often be a sign that the disease is already a bit more advanced.
Okay, now this is where it gets really fascinating. A patient's history gives doctors these crucial bits of context. I mean, you see the usual suspects on this list, right? Smoking, heavy drinking, no big surprises there. But look at that last one. New onset type 2 diabetes, specifically in someone over 50. Wow, that can be one of the earliest red flags for a cancer that's otherwise completely hidden. It's like this subtle signal the body's sending out that something is really, really wrong. All right, so the alarm bells are ringing. You've got the symptoms, you've got the risk factors. Now the real medical detective work begins. It's time to assemble the evidence and figure out exactly what's going on.
And the investigation kicks off with a hands-on physical exam. I know, it might seem a little old school in our high-tech world, but it can turn up some absolutely critical clues. A doctor might feel for something called Courvoisier's sign. That's an enlarged gallbladder that doesn't hurt when they press on it. It's a classic sign. Or they might find swollen lymph nodes. These are the kinds of physical clues that point the way forward.
Really, you can picture this whole diagnostic process like a giant funnel. You start out really broad, right, with the patient's story and that physical exam. Then, things get a little more focused with a whole battery of blood tests. And finally, you get to the narrowest, most detailed part of the funnel, and arguably the most crucial, which is the advanced imaging.
So in those blood tests, there's one really key piece of the puzzle they're looking for. It's a tumor marker called CA19-9. Basically, it's a protein that pancreatic cancer cells tend to shed into the bloodstream. Now, look, it's not a perfect test, it's not a diagnosis all by itself, but a really, really high level, that's a strong hint that something malignant's going on. And here's a pro tip, it's most accurate after any jaundice is cleared up, because the blockage itself can kind of mess with the numbers and give a false high.
And this brings us to a really critical point. You have to get the right kind of imaging. Seriously, not just any old CT scan is going to cut it. The gold standard is what's called a pancreatic protocol CT scan. Think of it like this. They use a special contrast dye, and the timing of the scan is perfectly synced to when that dye makes the healthy pancreas tissue light up bright white. Why? Because that makes any tumor, which doesn't soak up the dye in the same way, stand out as a dark or hypodense spot. It's all about creating that contrast.
Okay, so let's say the imaging points to a tumor. We've found something, but the investigation is far from over. In fact, it's about to get even more specific, because now the question is, what exactly is this thing? What kind of cancer are we dealing with? And trust me, that answer changes everything. And here's why that's such a critical question. Not all tumors that show up in this little neighborhood of the body are the same, not by a long shot. The most common one, pancreatic adenocarcinoma, well, that's the one we hear about most. It's very aggressive. But you could also be looking at an ampullary or duodenal cancer. And the big difference with those? They tend to cause jaundice much earlier, which means they get found sooner and, thankfully, have a much, much better prognosis.
And then, every once in a while, the biopsy comes back with a total plot twist. Something like a primary pancreatic lymphoma. Now, this is super rare, but it is so important to identify it. Why? Because the treatment plan is completely different. You're not starting with surgery, you're starting with chemotherapy. And the amazing thing is, the success rate, the remission rate is way, way higher. It's a total game changer. So, Once the cancer type is nailed down, we get to what is, without a doubt, the single most important question, the one that dictates everything that comes next. Can we get this thing out with surgery?
And you might think this is about how big the tumor is, but it's not. It's all about location, location, location. Specifically, its relationship to the critical blood vessels, the major arteries and veins that are all wrapped around the pancreas. That's the whole ballgame. Is the tumor just kind of leaning up against them, or has it actually grown into them?
This table right here, this is basically the rule book. This is the critical decision-making tool. You get a whole team of experts, surgeons, oncologists, radiologists, all huddled around the scans, analyzing them in microscopic detail. And they use these incredibly strict criteria, measuring the exact angle of contact with those vessels, to put the tumor into one of three buckets: resectable, which means let's go to surgery; borderline, which is a maybe; and irresectable, which means surgery is off the table, at least for now.
Okay, so based on which one of those three buckets the cancer lands in, the medical team opens up a very specific playbook. There's a different game plan, a different strategy for each and every scenario.
All right, let's start with the best-case scenario. If that tumor is deemed resectable, the goal is crystal clear, and the path is direct. Get it out. Get it all out.
The standard game plan here is called upfront surgery. This means heading straight to the operating room for a major operation. The most famous one is called the Whipple procedure, which is a huge, complex surgery for tumors in the head of the pancreas. But it doesn't end there. After the surgery, the patient gets what's called adjuvant chemotherapy. Think of it like a cleanup crew sent in to hunt down and destroy any stray cancer cells that might be hiding out. This 1-2 punch significantly boosts the chances of a long-term cure.
But what about those borderline cases? You know, the ones where the tumor is just kissing those major blood vessels. Well, here the whole strategy gets flipped on its head. The goal isn't to rush to surgery. The goal is to shrink that tumor first.
This approach is called neoadjuvant therapy, which is just a fancy way of saying treatment before surgery. The patient gets a round of chemotherapy, and maybe radiation, with the specific goal of pulling that tumor away from the blood vessels. Then, after a few months, it's back to the scanner. It's like a test. If, and only if, the scans show the tumor has shrunk enough, then they get the green light to head to the operating room.
And finally, what happens when surgery just isn't on the table? This could be because the tumor is too tangled up in those local blood vessels, or because it's already spread to other parts of the body. When this happens, the goalposts move. The focus shifts away from a cure and toward control and, most importantly, quality of life.
In this scenario, the playbook has two main objectives. The first is to control the cancer's growth using systemic chemotherapy. That's the main weapon to slow the disease down. The second, and just as important, is managing symptoms. This means doing things like placing tiny tubes called stents to open up any blockages causing jaundice or sickness, and using really advanced pain management techniques. It's all about making sure the patient has the best possible quality of life for as long as possible.
So when you look at the whole journey, the big takeaway is that today's playbook is incredibly sophisticated and structured, all revolving around that one question: can we operate? But the real hope, the future of fighting this disease, might not be in perfecting this playbook. It might be in throwing it out entirely. The real question we're left with is, as we get smarter about genetics and biomarkers, can we shift the entire game from late-stage treatment to super early, targeted detection? Can we learn to win this battle before it even really begins?